Next, James Cheseboro is joined by Dr. Joseph Alpert, professor of medicine at the University of Arizona in Tucson and editor-in-chief of the American Journal of Medicine. They cover what's new with the target-specific oral anticoagulants.
Welcome to ACCEL.
Thank you so much, James.
And maybe you could tell us about the new oral anticoagulants, what they are and how they're functioning.
Yes, well, at the moment, there are 3 of the new oral anticoagulants approved in the United States. Dabigatran, which is a 2A blocker, as we've talked about, a thrombin blocker. And then there are 2 approved 10A blockers, that is much higher up in the clotting cascade. That's rivaroxaban and apixaban. And endoxaban has just been submitted to the FDA, and it's very likely their results were just the same as with the other 10As, so it's very likely that will be approved probably sometime in the next 6 to 8 months. So we'll have 3 10As that resemble each other in some ways and have some mild differences. And then we have a very different agent, the 2A blocker, the thrombin blocker, dabigatran.
But the 10As reduce the amount of thrombin generated, so they act in the similar fashion from still affecting thrombin, stimulating thrombosis.
That is correct, whereas the oral dabigatran blocks thrombin, but not completely. So the thrombin gets generated, but then its action is blocked. But of course, you can't know exactly how much thrombin there is, and therefore exactly how much dabigatran you need in there. So there is some of the thrombin that escapes, a small amount.
But the problem is with the oral anticoagulants for thrombin, that you need a binding affinity that's very high, which is what warfarin has.
Correct.
And that will inhibit the bound thrombin. But when you have a lower binding affinity, you don't inhibit the bound thrombin, and thus the arterial thrombosis is not as effective with the oral.
Absolutely right. So that there's a chance for a small amount of thrombin to escape and to set off a fibrin clot. And in fact, that is probably the reason, or at least that's what we think, that when dabigatran was tested with prosthetic heart valves, the plastic and steel valves, it failed. There was actually valve thromboses and the trial was actually stopped early. We have not tested the 10As yet. Again, as you just said, theoretically the 10As should be better. But the truth is, you don't know until you do it. And I don't know if it'll ever be done because, as you and I talked about, it's a very small market compared to the atrial fibrillation indication, which is a huge and growing market.
And tell us about the atrial fibrillation and these medications.
Well, there were 3, let's say 4 trials if we include endoxaban. So the endoxaban trial was just completed, published in the New England Journal, and basically resembled the trials for the 2 that have been approved so far, the Rocket AF for rivaroxaban and the Aristotle for the apixaban. All the 10A trials have been similar. They show decreased cerebral bleeding. Aristotle and the endoxaban trial actually showed a decrease cardiovascular mortality, small decrease, but definite. And the difference was, of course, in hemorrhage-related cardiovascular events with warfarin. As, again, we've talked about, when patients are on warfarin in the community with the individual doctors managing their warfarin, it turns out that really you'd be lucky to get half the patients to be in range. In a good anticoagulation clinic, it's 60-70%. In Holland, which is the world's champion in this area, it achieves greater than 80% in range. But again, most patients are not seen in the anticoagulation clinic. They're seen in community settings. And so that may be the reason that warfarin didn't do as well in these trials with respect to cerebral bleeding. The RELY trial was the one that tested dabigatran. It was the first one. They've all been published in the New England Journal, by the way, over the last couple of years. And dabigatran was the first of the new anticoagulants to be approved, quickly followed by rivaroxaban and then a little bit later by apixaban.
And then the other potential use is in acute coronary syndrome?
Yes, the only one to be tested so far in acute coronary syndrome in the ATLAS trial was rivaroxaban. It did decrease the primary endpoint of cardiovascular events, but there was more bleeding, and so the FDA has not approved that indication. To me, it's a little bit sort of interesting that it resembles the results of the older warfarin trials for acute MI back in the 50s and 60s that showed the same thing. You decreased cardiovascular events, but guess what? There was more bleeding, so that's why we don't routinely anticoagulate with warfarin every patient who's had an acute MI.
So this might be useful at a later time after the acute event.
No question. I mean, for example, let's say you had a patient who had an acute event and had atrial fibrillation. That would certainly be somebody that you might consider one of these. We call, the abbreviation is NOAC, new oral anticoagulants, one of the new ones. And probably, again, since there had been an arterial event, I would pick a 10A in that setting, just as you've talked about.
Maybe one has to be testing more in the future because thrombin is a key stimulator of platelet-rich thrombus in our arteries, like acute coronary syndrome, that maybe one of the anti-10A plus maybe a single antiplatelet instead of dual.
What you say absolutely makes sense. It's important to remember, though, that there was more bleeding when you added a platelet, even low-dose platelet agent, in the big trials. In all the trials, Rely and Rocket AF and Aristotle, there was an increased bleeding. And if you had two platelet agents, there was a very significant increase in bleeding. I always say Alpert's law of anticoagulation, the more effective the anticoagulant, the more bleeding. And it's not the fault of the anticoagulants. Of course, you've got weakened blood vessels, and the more you stress them, the more likely they are to bleed.
So, and they're also testing a low dose of these medications.
Absolutely. And I can tell you what I do personally. My hospital only has Riva on its formulary at the moment. And so there is a lower dose of Riva. When I see an elderly patient, particularly if they're diabetic or have some creatinine elevation, I always pick the lower dose for those patients. And again, if they have coronary disease, they get the lowest dose of aspirin as well, at 81 milligrams.
Now, these are also utilized for DVT.
Yes. So far, the FDA, only Riva has the indication both for prophylaxing for DVT and treating DVT and pulmonary embolism. But there are excellent trials that have been submitted to the FDA, both for dabigatran and for apixaban, and the results were the same as the Einstein trials with Riva. So it's very, very likely, again, within the next year, we will have 3 agents, and then probably another year down the road when the endoxaban DVT PE trials are concluded, assuming they're the same, and I see no reason why they wouldn't give the same result, we'll probably have 4 drugs that we can use to prevent, well, even 5, because you'll have enoxaparin, and of course you'll have regular subcutaneous heparin, so actually you'll have 6 choices for DVT prophylaxis and for DVT treatment.
So where do you see these going in the future?
What I'm told is that of new prescriptions, the majority these days, 70%, are for the new agents. For patients who are stable and doing well on warfarin, they're staying on warfarin, and I totally agree with that. There's no reason to, if you're riding a horse that's doing well, you don't change in the middle of the ride to a different horse. On the other hand, there are lots of patients that don't want warfarin because of, as you've talked about, inconvenience and the testing and the dietary restrictions. So a lot of people are choosing the new agents, and one of the major factors is just what's their copay. I always give the patients a prescription, and I tell them before you go to the pharmacy, you must call your insurance company and find out what it's going to cost. I don't want people fainting at the pharmacy when they get a bill for $500 for 3 months. And the copays can range for as little as $7 a month if you have very good insurance, up to $140 a month, which is, of course, that's a big mouthful to swallow.
Obviously, a discussion with the patient is critical here, and discussing the best way to help them. And then once they're on these medications too, one still has to see them to make sure they stay on them.
Absolutely right. And we have an anticoagulation clinic in our hospital. And I even send the patients for at least 1 or 2 visits, and then maybe once a year, once every 6-month follow-up, just to remind them what they're on and what the risks of bleeding are and so forth.
Well, excellent. And thank you so much for coming to discuss these new oral anticoagulants with us and what the future is.
Thanks very much for having me. It's always a pleasure to talk to ACCEL.